Hello, dear students. In this part 2 of drug therapy of Parkinsonism, I shall discuss the other drugs than levodopa and we know dopamine receptor agonist is an important group of drugs today for the treatment of Parkinsonism. Now, there are two groups of the dopamine receptors, group 1 D1, group 2 D2. Group 1 is divisible into D1 and D5 subtypes. They are stimulatory G protein coupled receptor found in corpus striatum, and D1 receptor directly excite the pathway. Whereas D2 group contains D2, D3, D4. D2 is of our interest. They are inhibitory through G protein receptors. They are also found in extrapyramidal nuclei and other pathways. And D2 receptors are inhibitory and act through indirect pathways. That is globus pallidus externa, whereas globus pallidus interna is involved in direct pathways. D3 receptors affect behavior and may be responsible for extrapyramidal reaction and drug abuse. That we will discuss in some other. Bromocriptine, pergolide, ropinirole, rotigotine, and pranipixole are the drugs which are available as D-dopamine receptor agonists or DA agonists. Bromocriptine acts on D2 receptors mainly, but is also partial agonist at D1. Pergolide stimulates both. Apomorphine has high affinity for D4, including D1, D2 receptor. And newer pramipixole, ropinirole are mainly D2 and D3 agonists. Because D2 receptors are mainly involved in causing Parkinsonism, therefore this is a good group of drugs. Now bromocriptine is an old drug, a derivative or ergot toxins. It is a potent agonist at D2 receptors, but with multiple other effects, partial agonism, antagonism on D1 receptors. Alone not a good drug, but when given along with other drugs, it is useful. It is not a good drug alone because it produces intolerable adverse effects: vomiting, hallucination, fall in blood pressure, nasal stuffiness, conjunctival redness, and fall in the blood pressure. Currently, it is less preferred in Parkinsonism, but is used in the treatment of prolactinoma, acromegaly, and adjuvant in type 2 diabetes mellitus. Ropinirole is an important drug today commonly used, which is a pure agonist at D2 receptors with highest affinity for D3 subtype also. It has a neuroprotective action. This drug can be used as monotherapy in mild early Parkinsonism or can also be used along with levodopa or co-levodopa, because levodopa is not used alone today. The purpose of use of ropinirole is to flatten the fluctuations, so it reduces fluctuation. It is started at low dose and gradually increased till 1.5 milligram can be tolerated by the patient. In most instances, the 2 to 8 milligram 3 times may be required, but the median dose is 1.5 milligram. It is well absorbed orally, and because of its longer duration of action compared to levodopa, it reduces fluctuations. It is better tolerated in younger persons than elderly persons. It is also used in the treatment of nocturnal restless leg syndrome. One derivative, rotigotine, which is also agonist as D2 and D1, is available as transdermal therapeutic system for prolonged continuous activity. This is being further investigated for the use. Pramipixole is another one that also has D2, D3 activity and neuroprotective action like ropinirole. It is also effective as monotherapy for mild Parkinsonism and can be combined with other two drugs. Orally, it is well absorbed but is not metabolized, so it is removed unchanged in the urine. In renal impairment, dose must be reduced. Again, it is started with a small dose and dose is built up over weekly basis. Mostly patient would require 0.5 to 1.5 milligram 3 times daily. A long-acting formulation is available for administration. Now, these two drugs have common adverse effects of sleep disturbance, hallucinations, confusion, suicidality, nausea, orthostatic hypotension, fatigue, or somnolence. Impulsive gambling have been found with the drugs. The reason is apomorphine is another dopamine receptor agonist that has high affinity for D4 receptors, moderate affinity for D2 and other receptors. It has alpha adrenergic activity to some extent, but has a low affinity for D1 excitatory receptors. It is approved subcutaneously or sublingually as a rescue therapy by the patient, self-administered as intermittent treatment for reducing fluctuations. So when there are off periods, patient can take it sublingually and there is a reduction in the underactivity, so patient becomes more active. However, it is very important to remember that it is highly emetogenic. It causes vomiting and therefore some antiemetic may be required beforehand. One must not use ondansetron, metoclopramide or prochlorpromazine because all cause abnormal movements and problems. Hypotension. The drug which is given to suppress vomiting due to apomorphine is trimethobenzamide, 300 milligram 3 times daily. And this complicates the therapy, using a drug and then using a drug for treatment. So this complicates therapy. In addition, apomorphine has abuse potential and may cause QT problems, abnormal cardiac rhythms. So limited activity is there. Another important group, as third group of drugs we can say, is called orthomethyltransferase inhibitors. Three drugs are available: entacapone, tolcapone, opicapone. Now, when we add one of these three drugs to co-levodopa, there is a reduction in formation of dopamine in the periphery. So it increases the fraction of the levodopa that reaches the brain. This is because some of them, tolcapone, opicapone and entacapone, all three are peripheral inhibitors of orthomethyl transferase enzyme. So more levodopa reaches the brain. It must also be understood that tolcapone also blocks central COMT enzyme, so it reduces conversion of dopamine to orthomethyltyrosine. Therefore, it reduces inactivation. Indirectly, it increases the central concentration of dopamine in the striatal neuron. So this is a beneficial action, using a drug to increase dopamine concentration in the brain. This COMT inhibitor increases half-life of levodopa and greater friction, and therefore it must be understood how these drugs are acting. We have already used levodopa carbidopa. Now we are using telcapone and entacapone for reduction in the peripheral conversion of levodopa. We are also using a central acting COMT inhibitor, which is tolcapone, not entacapone. Central acting tolcapone reduces conversion of levodopa to COMT and also dopamine to inactivation. So it is a dual action which is more useful to increase the dopamine activity in the brain. Simultaneously, inhibition of the peripheral decarboxylase inhibitor increases dopamine level, where it is converted dopamine level because levodopa is converted into dopamine. So this three drug combination will provide greater dopaminergic stimulation in the nigrostriatal pathways. So this now differences are there between entacapone and tolcapone. Tolcapone is both central and peripheral inhibitor. It is somewhat longer acting but may cause greater hepatotoxic activity. Common adverse effects are nausea, orthostatic hypotension, dreams, confusion, hallucinations, and orange discoloration of urine. The other drug that causes orange discoloration of urine is rifampicin, if you remember. Diarrhea may occur more frequently with tolcapone, and fixed dose combinations for the both drugs are available in the form of the entacapone or tolcapone along with levodopa carbidopa in a fixed dose combinations, and these are very effective in reducing fluctuation and increasing the motor activity. Next group of drugs is monoamine oxidase inhibitors. We all know that monoamine oxidase enzyme is involved in intraneuronal conversion of monoamines, adrenaline, noradrenaline, and serotonin into their inactive products. For example, serotonin is converted into 5-hydroxyindole acetic acid. Similarly, monoamine inactivates adrenaline and noradrenaline, including dopamine. We have already discussed that. Now, there are two types of the monoamine oxidase enzymes. One is type A, to easily remember, alimentary canal, and type B in the brain. However, their location is brain, GIT, liver, placenta, skin. Mono B is present in brain, platelets, lymphocytes. So we can say that a substrate for monoamine A is serotonin, noradrenaline, dopamine, tyramine, whereas substrate for B is not the tyramine. Dopamine is substrate for both, and the blocker of A, B, and both are available. Those which are non-selective blockers are called as A and B blockers. They are old drug, trenylcypromine, iproniazid. They are not used or very uncommonly used. For example, phenelzine. The monoamine oxidase A inhibitor are chlorgelin and moclobemide, whereas monoamine type B inhibitors are very important drugs which are used in Parkinsonism, salicylic and rasagiline. So we will be talking of monoamine oxidase B inhibitor because in brain they will inhibit the dopamine inactivation. Salicylic and rasagiline are highly selective and irreversible monoamine oxidase B inhibitors in corpus striatum. Sulfonamide is reversible inhibitor of monoamine oxidase B. Now, monoamine B is present in the brain and platelets, but main action is on the brain, where there is an irreversible inhibition of enzyme. Since there is no inhibition of peripheral metabolism of amines, so it can be used along with levodopa. There is no lethal potential of the catecholamine action, and therefore Chase reaction, I will discuss this. Chase reaction also does not occur with selective monoamine B receptor in usual doses, but when doses are high, this may also occur. Dose more than 10 milligram, for example, usual dose is 5 to 10 milligram salicylic. If dose is exceeded, then there is non-selective action, inhibition of monoamine oxidase A. Salicylic can be used in the treatment of early Parkinsonism. It is well tolerated by younger patients, but it is commonly used as adjunct along with other drugs even in early cases. There is a prolonged levodopa action, reduction in the dose of levodopa further because salicylic also inactivates the dopamine peripherally, that is prevented, and reduces motor fluctuation, decreases wearing of phenomena. So there are the large advantages of use of this drug, but there is disadvantage. On-off period may not actually improve. and levodopa side effect may actually increase, particularly behavioral and neuropsychiatric side effects. Hallucination may worsen. One important thing is that the metabolite of salicylic include amphetamine and methylamphetamine, which may cause insomnia and anxiety, and therefore this drug should be avoided at night. Should be given during day. Oral dispersible tablet or simple tablet 5 mg or transdermal system is used to avoid pre-systemic elimination formation of amphetamine, and that will avoid the anxiety, insomnia and other adverse effects. This is how a change in the route of administration changes the manifestations or adverse effects. Development of stupor, rigidity, agitation, hyperthermia. For example, neuroleptic malignant syndrome type of thing may be occurring with the meperidine or pethidine use. So there is a contraindication. Pethidine should not be used with. Other monoamine oxidase B inhibitors are rasagiline, which is also as effective as salicylic monotherapy in early Parkinsonism. It does not make amphetamine-like metabolites. Salicylic makes. So insomnia will not occur because of formation of amphetamine. It may have disease-modifying effect for long term, and pethidine should not be given along with it. Increasing doses may also cause serotonin syndrome because excessive formation of serotonin, which is not inactivated by monoamine as it is inhibited. So limited dose limiting effect should be remembered. Sulfonamide is newer reversible. It additionally reduces glutamate release, but should be avoided in hepatic disease. As I told you, two types of the monoamine oxidase inhibitors and their different locations. Point to remember here is that dopamine is a substrate for A and B both, whereas serotonin is not the substrate for B, it is substrate for A. Therefore, and tyramine is not the substrate for B but substrate for A. So, if we use a monoamine oxidase inhibitor which is non-selective, blocks both A and B, or a monoamine oxidase inhibitor that blocks monoamine oxidase A, that will affect the tyramine metabolism. So this must be remembered. Now we should also remember that certain antibiotics also have monoamine oxidase inhibiting activity, isoniazid and zolid. Now let us talk of cheese reaction. Cheese contains large amount of tyramine, which is also present in beer, red wine, pickled meat, fish, fermented yeast, soy products, and this large tyramine may cause hypertensive crisis with monoamine oxidase inhibitors, non-selective or type A inhibitors. Now, tyramine is metabolized by hepatic and intestinal type A enzyme into inactive product. In persons taking monoamine oxidase non-selective inhibitors or A inhibitors, tyramine is not further inactivated systematically and large amount reaches into the circulation. Now remember, tyramine is a potent releaser of noradrenaline from adrenergic neurons. So large amount of the release of noradrenaline will occur, resulting in stimulation of alpha receptors and beta 1 receptors, and this will cause dangerous hypertension, stroke, myocardial infarction, and this is called as cheese reaction. Taking cheese by patients who are taking monoamine oxidase A inhibitors or non-selective inhibitors. Remember, cheese reaction will not occur with selective monoamine oxidase B inhibitors in usual doses. So, salicylic, rasagiline will not cause cheese reaction in adequate doses, unless doses are increased. That is very, very important. Now, neurotoxic theory of Parkinsonism. It is said that monoamine oxidase B present in astrocytes will convert a chemical found in natural products MPTP and methyl paraphenyl tetrahydropyridine. It is converted into a neurotoxic intermediate which is highly reactive ion MPP plus 1-methyl 4-phenylpyridinium ion. This neurotoxic product formation occurs through enzymatic activation by monoamine oxidase B. So if we are inhibiting monoamine oxidase B by salicylic or rasagiline, we are actually reducing formation of neurotoxic, neurodegenerative toxin. And there they call as neurotoxic theory of Parkinson and role of monoamine oxidase B inhibitors as neuroprotective agents in Parkinson. So they will delay the degeneration. This will slow the process. Now, monoamine oxidase B inhibitors protect dopamine oxidation to form free radicals also. So oxidative damage will be reduced. The monoamine oxidase B inhibitor when added to therapy will reduce levodopa requirement, so reduce dyskinesia. Remember, other drugs increase dyskinesia, but the B inhibitors reduce dyskinesia. That is important to remember. And they are considered as disease modifying drugs because they delay the occurrence of neurodegeneration in the striatal dopamine pathway by preventing formation of MPP plus neurotoxin. And it has been proved experimentally that reduction in the degeneration occurs in animals exposed to monoamine oxidase B inhibitors and to environmental toxin. Ladostigil is a brain-specific monoamine oxidase inhibitor, which also has additional anticholinesterase activity. Currently, it is under investigation for Parkinsonism and Alzheimer's disease. Among the other drugs, dopamine facilitators amantadine. It is basically an antiviral drug used to prevent influenza A. Mechanism of anti-Parkinson's action is that it potentiates the dopaminergic function in corpus striatum by blocking the reuptake of dopamine, releasing dopamine from the stores presynaptically, and it also acts on dopaminergic receptors postsynaptically, and therefore it has a modulating effect by dual action, presynaptic and postsynaptic action. Addition property of amantadine is that it has anticholinergic activity in the brain and also blocks NMDA glutamate stimulatory receptors, so there is less excitation. Additionally, it also antagonizes the adenosine effect on the adenosine receptors that may inhibit the D2 receptors. So there is no inhibition of the D2 receptor by this mechanism. So these multiple actions of amantadine make it a useful drug as add-on drug for Parkinsonism as well as for Parkinsonism. Alone, it is a weak drug. It may reduce dyskinesia without worsening of the motor weakness. Initiation of therapy can be done with amantadine in mild Parkinsonism. It improves all manifestations, but the benefits are short-lived because of tolerance. That is important. It is preferred in drug-induced Parkinsonism, antipsychotic drug-induced Parkinson, because of its anticholinergic activity. And it reduces drug-related fluctuations dyskinesia by combination therapy. We use long-acting preparation twice daily or once daily. The main problem is dizziness, lethargy, anticholinergic actions, may be mild, but excitement, hallucination, confusion may add with the levodopa, and therefore adverse effects may be there. The typical adverse effects of amantadine are livedo reticularis and peripheral. Estradephyllene is like aminophylline or theophylline, an adenosine A2 receptor antagonist. It is FDA approved for adjunctive therapy to control off periods in Parkinsonism. Currently, it is not available. What is the role of anticholinergic drugs in the management of Parkinson? Several tertiary anticholinergics having marked central antimuscarinic activity, benztropine, piperidine, procyclidine, and trihexyphenidyl. Trihexyphenidyl is also known as benzhexol. It is virtually most commonly used drug for drug-induced Parkinsonism. Reduce unbalanced cholinergic overactivity. Tremors are benefit more than rigidity. There may not be much effect on akinesia. Overall activity is lower than levodopa, so they are useful in mild cases. When levodopa is contraindicated, they can be combined with levodopa to reduce the dose of levodopa, and when you want to further control tremor. It is anticholinergic drugs, benzhexol, drug of choice for drug-induced acute dystonia, Parkinsonism. Certain antihistaminics, orphanadine, promethazine, they also have anticholinergic activity, so they are useful in drug-induced Parkinsonism. All anticholinergics and these drugs have short-lived action, about 8 hours. Benzhexol and promethazine are available, so they are very useful in drug-induced Parkinsonism. Now, other modalities of treatment for Parkinsonism, if psychosis occurs, don't use a conventional or atypical antipsychotics, use pimavanserin because it has different site of action than others. Others will cause drug-induced Parkinson's. Do not use risperidone or olanzapine also. Cognitive impairment and psychiatric manifestation may also be helped by using rivastigmine, although it is a paradox that it is anticholinergic but not anticholinergic drug. But it may be required for cognitive impairment improvement. Physical therapy, high frequency stimulation of subthalamus or globus pallidus interna improves motor function. Focused ultrasound thalamotomy or stereotactic radiosurgery may be helpful. Patients with medically refractory tremor, predominant Parkinsonism, who are reluctant to undergo surgery would require ultrasound thalamotomy. But surgery, ablative thalamotomy or pallidotomy are found to be useful. Ultimately, neural tissue transplants have also been studied for better outcome. All these are required because ultimately, as time passes, after 5 years of therapy, patients on levodopa or other therapies do not show improvement, or the improvement decreases because there is critical reduction in the dopamine neurons and dopamine receptors. Nothing is left, so whatever drug you give, it will not help. So ultimately, patient becomes homebound and moribund. And in this patient, this type of therapy may be on-demand therapy in Parkinsonism to avoid off periods. I told you sublingual apomorphine patient can take. During off periods, one may use inhaled levodopa or sublingual apomorphine. Why is it important in elderly? Because off periods may result in falls and choking, and they can be chronic tardive dyskinesia. Now, a word about drug-induced Parkinsonism, usually reversible. Chlorpromazine, fluphenazine, haloperidol, metoclopramide, reserpine, prochlorperazine, all are associated. There is no neurodegeneration. It is abnormal function. So it is short-lived, treated by drugs. The points to remember in the last is none of the present drugs alter basic pathology of Parkinsonism. Initiation of levodopa therapy, co-levodopa should be delayed as far possible. जब तक पेशेंट चलता है नॉर्मली उसको देयर आफ्टर मोटर मूवमेंट्स आर markedly reduced, bradykinase is there, posture, gait changes at the end start. Monotherapy with salicyline or anticholinergics or amantadine in mild cases. Newer drugs, ropinirole may also be effective. In deterioration phase, levodopa, carbidopa, and addition of doses, increment in dose carefully. Benefits from drug therapy wear off, dyskinesia develop, later on-off phenomena develop. Patient's problem becomes same as with the drugs or without drugs. Peripheral decarboxylase inhibitors decrease early but not late complications. Dopamine agonists like ropinirole are used to supplement levodopa to prevent on-off phenomena. COMT inhibitors like entacapone are added to levodopa carbidopa to prolong their action to reduce. So this is all about Parkinsonism, so as pharmacology is concerned. Now let's take some quick questions. Which one of the following symptoms are not improved with levodopa? Tremor, rigidity, dementia, dyskinesia. The answer is dementia because neuropsyptic which may actually increase. Carbidopa addition to levodopa does not improve postural hypotension, nausea, vomiting, rigidity, on-off phenomena. Postural hypotension may actually increase because there is more formation of dopamine. Which heavy metal exposure causes Alzheimer's-like dementia? Lead and sulfate. Which heavy metal exposure causes Parkinson's-like disease? Manganese toxicity. Which heavy metal exposure causes tremor, ataxia, dystonia? Copper, Wilson's disease. Which heavy metal causes tremor, paresthesia? An antipsychotic which is least likely to cause EPS is triclozapine, haloperidol. You remember clozapine was used for drug-induced Parkinsonism in chronic tardive dyskinesia or akathisia. Therefore, this causes least likely extrapyramidal reaction can be used. Treatment of drug-induced akathisia is propranolol, salicyline, rivastigmine, valbenazine. Propranolol is a drug which should be used first. Measures to reduce fluctuations with levodopa will include all except salicyline, ropinirole, increasing levodopa, drug holiday. So all will decrease the fluctuation, but levodopa will not increase. It will ultimately result in bad outcome. Anticholinergics are most effective in controlling bradycardia, tremor, rigidity, hypotension. Bradykinases, rigidity, hypotension improved late or less. Tremor is much controlled with. Here the greater fraction of levodopa is not as dopamine. More levodopa goes, not dopamine goes with carbidopa. An anti-Parkinson drug that increases dopamine and also has anticholinergic activity. So we have learned amantadine is a drug that has both activities. An anti-Parkinson drug that has anticholinergic activity and reduces tremor and is useful in drug-induced dyskinesia is drug-induced dyskinesia. The answer is central anticholinergic and that is benzoxazole. Others are anti-Parkinson's drugs. Confusion and psychosis due to long-term levotherapy is best treated by pimavanserin. Others should not be used in the treatment. Typical antipsychotic agents and second-generation antipsychotics, olanzapine, risperidone, may cause worsening of the motor symptoms. Should be avoided. Clozapine may be effective, but we have not given clozapine here. Thank you. So this is all about the levodopa and other